can't really point out exactly why, but if you look at the different components, so the first one is sort of a kind of a medical term here, subchondral bone sclerosis. In layman's terms, it simply means you have bony thickening due to repeated trauma. So if anyone's heard of bone-on-bone before, when you lose this joint space here, so you have normal here and abnormal here, you'll see on the right side, the abnormal knee, you'll see that the joint space is narrowed. So when you lose that joint space between the bones, you'll have repeated trauma every time you're taking a step. So that actually causes thickening of the bone, and you can see that in the white on the right side here at the joint line, and that's what we call subchondral bone sclerosis. The radiologists, they actually look for that. So usually when you get a report of your knee, like an x-ray, they'll just say osteoarthritis of the knee. And this is just breaking it down to kind of pull out the reasoning of why the radiologist called my knee build-up side of the knee. I don't know if you can see it quite well. On both sides of the abnormal x-ray, you start to see osteophytes. And then I spoke about the joint space narrowing there. So normal and abnormal, and this view is the AP view, so you're looking straight down into the knee. This is an x-ray of a patient I took about a week ago. So as you know, this is an abnormal x-ray. Right off the bat, you see that there is subchondral sclerosis, bony thickening at the joint line, more on the right side. You also see that the joint space is quite lacking. You have some joint space here, but if you look onto the sides, and you compare it again with the normal image here, you don't have this, you have this joint space narrowing, you don't have that real estate right within the knee. And what makes this even worse is that this was not even a standing x-ray. That means this patient was laying down and the joint space was already compromised by this point. If you look on the right lower side, you'll see the bone spurs here, and coming cut off here, but you can appreciate the threefold diagnoses on this AP x-ray. So I'll talk about the conservative treatments, the medications, including injections, not so much surgery, but I will see if I can invite an orthopedic colleague of mine to talk about surgical options. But I'm really talking about conservative treatment, what you could do or what you could take and what you could get done without doing a knee replacement. So the main conservative therapies include hot or cold compresses. Now, hot or cold compresses with non-steroidal medication are typically the mainstay. If you go to an orthopedic or sports doctor, they'll say elevate it, put some ice on it, take some anti-inflammatories. But patients always ask me, okay, they say use heat, use cold. So what do I do? Well, usually within the first 5 days of knee pain, let's say if you kind of twist your knee or you just have an episode of knee pain, I typically say or recommend cold compresses. And usually after the 5-day mark, I usually say start to transition to a hot compress when things get a little bit more chronic. Weight loss is huge. Most patients who do come and see me for knee pain are not a lot, but a little bit overweight. I think there's a lot less emphasis these days about the type of stress on the knee joints. So the next typical response, I can't go to the gym, therefore I'm kind of stuck at this state. Well, I would say studies show that at least 85% of your weight is actually managed through your diet. So at least we don't put in local anesthetic there because there's a motor nerve that actually lives there. And if we inactivate it, then it'll cause a lot of weakness in the legs, so we actually avoid this side. And this 2 insides here and the upper outside is typically what you get mobilized with the anesthetic. So if we find that that benefits you for even a short while, we have you come back in and we actually do an ablation. So an ablation simply means to inactivate something in a medical sense. Okay, so we go to those same areas where we injected the local anesthetic, and we actually heat the surrounding tissues using a special radiofrequency needle to about 80 degrees centigrade for about a minute and a half. That's been scientifically shown to inactivate it. So it's not like a hot needle going in and burning your skin all the way down. And it's actually a needle that's connected to a radiofrequency machine that allows surrounding tissue to heat up for that amount of time. So it could be safely done in the clinic, and it's done quite frequently. Another type of injection is PRP, or platelet-rich plasma. So this has gained a lot of traction because you're not using an outside substance, nothing synthetic, you're not using a steroid. You simply get your own sample of your blood, you spin it down 3,400 RPMs, and then you actually extract the platelet-rich plasma and you inject it into your own knee. So it's sort of like a tissue transplant, people say, of your own cells, in which you're using the healing factors of platelets to kind of regenerate cartilage in your knee. So this is a brief schematic on how it's done. You get a little bit of anticoagulant, you draw it in a syringe, and then you take a sample of the patient there, and then you actually spin it down in the centrifuge, 3,400 RPMs, you extract the platelet-rich plasma, and you inject it into the knee. So there's increased research focus on this, but there's a lot of literature out there in medical journals that shows that this is a very helpful therapy. Here are some of the papers out there. That's me just extracting a sample of PRP. It's not only the knee, you can also get it injected in facet joints in the neck as well. The most common areas in which where PRP helps, the dentist first used it for osteonecrosis of the jaw when they're having, a lot of their patients were having issues with kind of osteoporosis medications. They're having jaw pain or jaw necrosis, and they actually injected the PRP for restorative purpose. But the most commonly published data comes from the elbow joint. It works in the shoulder and works in many other places too. Any questions at all? This is just a brief overview with knee pain. I know this is a lot of material. Yes.
Does that work in the neck as well?
Yes, so the question is, does PRP work in the neck? It does. There's only certain places you could get it injected in the neck. That's the facet joint. I don't recommend PRP to be injected into the central canal or through an epidural. There's been not a lot of studies in terms of that. There could be a lot of risk, but there are small synovial joints in the back of the neck, which I'll talk about in the neck part of this talk, but small amounts of PRP have been shown to be beneficial.
You mentioned about that using the cold or hot compress. Can you explain what you should do so that helps us to remember when to use what?
Okay, so when patients come to me and they say, okay, so I have a hot compress and a cold compress at home, the whole notion of that is typically when things are acutely injured or you start having an acute episode of pain, this is when something gets disrupted. You get a lot of pain mediators that start to go to the area and you get a lot of swelling. And sometimes that swelling is reparative, and sometimes it's not. Sometimes it causes more problems. We see that in other areas of the body. We see that in the neck. But in the knee, when you have a lot of swelling there, sometimes you do need to elevate the leg to decrease the swelling, and you do need to put a cold compress on there to alleviate the swelling part. Usually after the 5-day mark, if it's not post-surgical, I usually start to recommend a hot compress because usually the swelling has gone down by then, and the hot compress actually just vasodilates the vessels around the knee and actually increases the blood flow. So if there's anything reparative, it allows the knee to actually do that.
Do you take HMO patients? And I have Optum Care. Are you in network?
No, I'll tell you what happened with Optum. Optum is looking for their own pain management group, and they want to employ their own pain management. So we used to work with Optum, but I think they hired their own pain management group to manage their patients. So I can't speak for the insurance, which of these they actually cover. I would talk to at least one of their primary doctors to see, because their model is kind of restrictive on different procedures you could do. So these are the general procedures, and I'm not sure insurance by insurance, but best to talk to your primary or your pain management often to see if they actually cover these.
The PRP, is that kind of like a stem cell replacement? And does it actually regenerate? What do your studies show? How does it regenerate cartilage? How long does it last? How many treatments do you need? And is it covered by Medicare?
Okay, good question. So PRP is shown to have a biostimulatory effect. So instead of an anti-inflammatory effect, it's the actual opposite. Okay. It's the actual opposite of that. It actually increases inflammation. It recruits inflammatory cells, and the whole goal is to stimulate the chondrocytes. There have been studies that show that there is a regenerative effect. The theory on how this happens is still yet to be elucidated. They think that the platelets actually carry these growth factors and actually locally increase the reparative function of said joint. It seems to work the best in the knee and the elbow, facet joints and the jaw. You've probably heard of PRP being injected in many places, but the evidence of that, I mean, people use it for hair loss, people use it for just about anything that you can regenerate. But in terms of pain, it has pretty good efficacy. But the best studies come from the elbow and the knee. Yeah. So is it covered by Medicare? Unfortunately, it is not, but I think eventually it is, because so far it's been an out-of-pocket thing, and it doesn't involve any medications, and it's a very safe procedure. While I was in New York, I launched a study on PRP and facet joints, and there was efficacy for that too, but that's still being published right now.
What is the cost rather than paying out of pocket?
For platelet-rich plasma? It varies. There are some groups, I think the trick is, and don't quote me, if you go to more kind of, I guess like places where there's just a lot more people paying a lot more out of pocket for this stuff, you typically pay a lot more. So if you go to like, don't quote me, you go to like Newport Beach, some people are paying a couple thousand for this, and that's a little bit steep, but in our clinic, our price is about $800, but we're not there to really compete with people, but that's been our price for quite a long time. And this could be safely done in the office, and I would get a few quotes of this before you actually do the injection, because it's, as long as they spin it down for at least 5 minutes at a certain RPM, 3,400 is typically the standard. People, this PRP is pretty easily obtainable, and sometimes, I'd rather have you folks go to a clinic that does it correctly and charges you correctly versus, kind of making the price too high and trying to make too much of a profit. So that's usually the average price there. So.
By the way, this session is being filmed, videotaped.
Yes, I believe you mentioned you have a lumbar pain presentation. How do we see that?
Well, two years ago, I did a presentation on Zoom. I'm not sure if it was recorded.
We probably did.
Okay, you could ask Mrs. Derby that to see if she has it in the archives. But I'll be happy to give a low-back presentation as well. Okay, so yes.
I had knee surgery about 15 years ago, and it's, once in a while I get pain. What would happen? Do you have idea what kind of treatment for post?
Yes, so good question. So out of the different treatments I briefly touched upon, the one you would actually be eligible for is the ablation. The ablation was actually designed for patients who are having pain after surgery. So when you have a bionic knee, you can't really access the knee. There's no capsule to put the medication in. Actually, even if there was, I highly would recommend getting a steroid injection in a knee that's been replaced. That's a huge infection risk. So the RFAs, or the radiofrequency ablations, focus on the nerves outside the knee that allow you to feel the knee. So typically I do it for patients who've undergone some type of knee replacement. They're still having pain from their replaced knee. So good question. Okay, so yes.
Is it one-time treatment, injection, platelet injection in one time, or?
Depends on which injection. So the steroid is typically done every couple of months, depending on your condition of the knee. There's a lot of exceptions. For me, I had an injection in my shoulder about 14 years ago. But for some people, they have to get repeated injections. For the platelet-rich plasma, it's usually a one-shot injection. For the gel injections or the viscosupplementation, it's usually 3 injections, 1 a week for 3 weeks. For the gel injections, it's very uncommon for you to just get 1 injection. It's usually a series to actually, to replenish the knee of that hyaluronic acid. And the RFA is typically done once every 6 to 8 months, but for a lot of people, I've only had to do it once, and they get relief. So, okay, so I'll briefly talk about neck pain. I'll kind of rush through this a little bit, but neck pain is a very difficult thing to kind of measure in our society. So there was a Swedish study that estimated about suffers from some kind of neck pain. And there's different causes of neck pain, many causes of neck pain, a lot more than that list of etiologies of knee pain that I showed you. But I'll really be talking about 3 major causes of neck pain and why patients come to see me. And that's myofascial syndrome, cervical facet syndrome, and spinal stenosis. So myofascial syndrome can result to general debility from trauma or just due to poor posture. So in a medical sense, it's basically a band of kind of a hyper-irritable skeletal muscle. And there's pain when you press into that muscle, and sometimes they call this a trigger point. So as you can see here, this is a diagram of a lady who actually has a trigger point at the right base of her neck, and someone is examining her and she could say, yes, that's a spot. Every time I push there, it's very painful. Trigger points could be in virtually any part of the body where there's skeletal muscle. So the more treatable areas tend to be the shallow soft tissues, because that's where we actually could reach when we do procedures. This is a schematic of where the typical areas of trigger points are. I know many of you could relate to this. I know I can. There's some areas in the back of the neck, and then there's areas behind the shoulder blade and down into the buttock and the lower back. So once again, trigger points are kind of hyper-irritable loci within a band of skeletal muscle. So the reason why the shallow soft tissues are the areas we treat is because to treat this, typically in the office, we do trigger point injections. So these are typically injections done with the fine needle to access a band of kind of a painful band of skeletal muscle. As you can see in this image, a patient has been sterilized. These are ultrasound-guided injections in which we identify the painful skeletal muscle band, and we actually use a fine needle to put some medication in there. The medications could vary. They could be anti-inflammatories, they could be steroids, they could be local anesthetics. Some people use PRP, but the evidence there is sparse. The next common cause of neck pain is pain coming from the facet joints. So cervical facet joint syndrome was first described in 1933 by Dr. Gormley. All he thought was, well, this was a big theory of his, these areas which he didn't know were joints yet were elements of the posterior or behind the neck that cause symptoms in other parts of the neck. For instance, these are the types of pains that when you would get looking upwards or looking side to side, a lot of these pain issues are associated with headaches, especially in the back of the head. This diagram describes the location of that said facet joint. So if you have a painful facet joint, such as the C2-3 joint, this map attempts to localize or to map out where that pain radiates from that facet joint that's affected. Usually facet joints in the neck, if they're painful, usually groups of them, of at least 2 facet joints actually are the cause of the symptoms, and they start to radiate in different places. So if you look closely in this diagram, the C2-3, when you look upwards or when you kind of touch your chin to your chest and you move left and right, if you start having symptoms radiate down, radiate up the back of your head, and that's typically where it travels. For the C3-4, sort of in the middle of the neck, when you get lower, in the lower parts of the neck, you start to have radiation of that pain in the back of your shoulder blades and sometimes further down. Here's another image. So we're able to make a diagnosis of facet joint syndrome by actually anesthetizing a nerve that allows you to feel that facet joint. And if it results in significant neck pain relief, then you can actually do an ablation. So we do ablations of these nerves as well in the office. This is a diagram of a radio frequency needle, very similar to the one we use for the knee, that actually could go to this nerve that allows you to feel that facet joint. And we know in pain management, just because you don't feel an area in your body doesn't mean that area ceases to function. For instance, if you can't feel your knee, and if you don't feel the pain there, it doesn't mean that the knee will stop holding you up. These are structural elements of our body, and sometimes we treat these joints in which we don't necessarily have to feel. So if we burn these nerves, it doesn't mean that our necks will not hold us up anymore. We'll just feel less of our necks, which for most of us, it's a good thing. So spinal stenosis, I'll talk about briefly. If you think of the actual spine as a tube, because the most common question I get in clinic is, what is stenosis? Stenosis is simply a medical term for blockage. So if you think of the spine as a tube, the spine is trying to protect the most important organ in your body, your brain and your spinal cord. If you don't have those, you just don't function at all. So you're born with this kind of tube that has a spinal cord inside and its neural elements, the nerve roots that travel outwards. And as you age and with degeneration, you start to have elements that encroach within the central canal, within that tube opening. That's when you start to have problems. So the most common cause of spinal stenosis are bone spurs and disc herniations. So if you've probably heard of a herniated disc in the back, herniated discs in the neck are not as common, but just as painful. So if you've heard of sciatica in the back, there's a sciatica for the neck. So if you put the 2 and 2 together, for a herniated lumbar disc, it typically radiates down into the legs, because that's where the nerves that come out of the low back, they actually travel to the legs. The nerves that come out of your neck, or the cervical region, radiates to the arms. So you'll have a sciatica, if you will, but it's not the sciatic nerve, but it's a pinched nerve that goes down into your arm. And this is a diagram of like a sciatica that you could get in the neck and in the upper extremity. So most people don't feel this right away, but they start feeling a little bit of pain in the wrist, sometimes in the hand, a little bit of numbness, but it's very difficult to put the two together. Some people just come to clinic and they have arm pain or shoulder pain, and it's not within the joint, it's just the general area, and they can actually accentuate their pain by actually moving their neck around. In fact, there is a neurosurgeon by the name of Dr. Sperling, in which he came up with the Sperling maneuver, in which if you have pain going down the arm, typically when it passes the elbow, if you touch your chin to that arm, to that shoulder on that same side, and it actually makes the symptoms worse, that's usually associated with the pinched nerve or an element of spinal stenosis. So as you can see here, this pain is shooting down from this poor gentleman's arm all the way down past the elbow. It's not only pain, it typically starts with numbness, and then it progresses to pain, and it can be associated with weakness or motor deficits if it becomes more and more severe. So this is a diagram that points out the dermatomes, which are basically general maps for most of us. Our bodies do follow this, not to, to the exact color code there, but this is a general diagram that shows that when you have a pinched nerve in a certain area of your neck, it starts to affect other areas of the neck and upper extremities. So it's not only pain, it's weakness, and it's also numbness. So this actual table talks about the different areas in which you could have stenosis in your neck and what would be the clinical outcome. So this is a little bit jumbled, but if you were to get a pinched nerve at C5 per se, which is kind of like the mid-lower part of the neck, you'll start to have issues with your bicep strength, you'll start to have issues with rotating your shoulder a certain area, and then you'll start having weakness in certain types of motions there. Same if you go all the way to C8, which is the last spinal nerve that comes out of the neck, you'll start having issues with hand grip, you'll start having numbness in your pinky and things like that. So I'll just briefly talk about interventions for spinal stenosis in the neck. One of the things we do in the clinic are injections of a steroid. So this is a picture of an epidural. So if you look here, this is the front of your neck here, this is the back of your neck, this is a needle here. This could be safely done in the clinic with x-ray guidance. Make sure wherever you go and have these injections, these are one of the most common injections done in the clinic. However, you make sure that your provider is using image guidance throughout this entire process. So you can see that a little bit of contrast. So you see that in the dark here, a little darker here, that shows the epidural space. And steroids have been shown to have a moderate degree of what they call helpfulness or efficacy when injected for patients with spinal stenosis. So I would say that's about it. My office is at 3851 Catella Avenue, and I'll be happy to answer any questions, or if you want to ask me about low back pain or shoulder pain or hip pain, I'm there to answer them. So thank you very much.
I'd like to ask you, when you turn your head from side to side and you have that gritty sound in the back of your neck, is that something to be concerned about, or is that just part of?
Well, that could be coming from a couple areas. It could be coming from the vertebral bodies on top of each other, the bones on top, and the facet joints. So those elements really connect each vertebral body or level of their spine to one another. When you turn left and right, sometimes you stress the facet joint, but the grinding sensation could be due to the lack of joint space there too. So it could be sort of like a bone-on-bone sensation. Not necessarily painful for a lot of people, but kind of alarming, especially when you hear, when you could hear it because it's just, inches away from your ears. But it doesn't really require treatment unless you start to have pain with movement. If you start having pain with movement, first of all, I would get an x-ray to make sure that there's nothing structural that's abnormal, but it's usually an element of osteoarthritis between the facet joints in which you could get.
On your last comment then, make sure whoever used image guidance, what does that mean?
Well, it just means that this injection is in a very sensitive area in the neck, and the neck is a little different than, let's say, the low back, because you have almost the same amount of structures within a very smaller area. So whichever provider, if they were to do the injection, it has to be 100% image guided. That means that not only do they use an x-ray to do this procedure and with proper positioning and sterile technique, they're going to have to use a contrast. So they actually, when they get into the area they intend to, they actually put some medicine in to make sure the medicine flows in that area that's in target. Because oftentimes if you do a lot of these, if you do an injection just because you're in the target, the medicine could backflow, it could go somewhere else, and the last thing you want is to get some of this medicine in a vessel or within the interspinal space where it shouldn't be. So the contrast really guides providers like myself to put it in the right area. So it's imperative that, you know, if you were to get this injection, you ask, is this done under an X-ray? And if so, is the X-ray on most of the time? Or, you know, some people just take one X-ray, but you want to make sure that they're taking multiple X-rays while they're doing this procedure, just for your own safety. Yeah.
1, 2, 3.
Oh, thank you. I just wanted to say 4 years ago, I had a fusion in my neck of C5, C6, because the symptoms were the pain down my arms, hands, and of course that's all gone now. It's all fused, but of course I've lost a lot of my, I don't know what you call the rotation, so when I drive, I just turn my whole body to, you know, to check for cars.
Yeah, sometimes, so you get that loss of range of motion, but a lot of times that starts to become painful. So when you have an element fused in your body, especially the neck, because in the back you could kind of make up for it, you know, you could turn your whole body, but the neck, it's really hard to do this for a long time, especially when you're driving, it's just not possible. So in the neck, when you have an element fused, you typically, over time, get degeneration of the joints above and below the fusion. That's called adjacent segment disease. So that's when you could get a facet injection in those areas and an ablation, so you don't feel as much as the pain as you're turning left or right. But in terms of the range of motion, that's going to be a difficult one to get back, especially with a fused segment. Yeah, but you know, surgeons are actually recognizing more and more that their surgeries actually sometimes cause some more problems, like not only range of motion, but increased pain in other areas, typically above and below. And now I see more surgeons just putting it out there, hey, you're going to get this adjacent segment disease. You're going to have to be willing to live with this if this surgery, even if it goes well. It's just so common. So.
But I'm out of pain.
Oh,
I'm
that's
out of
good.
pain.
That's good. Yeah. That's good.
Okay, who was the second person?
Does your office have modalities? Are you familiar with issues with chronic pelvic pain?
Yes, so yeah, we do procedures with chronic pelvic pain as well. Usually our pelvic pain patients are managed with a mix of medications. They try laser therapy, they try abdominal wall injections, and certain nerve blocks and denervations. And that's typically done safely.
When I'm doing exercise, and then I move my arm kind of like in a circle, and I heard, the noise of grinding bones. It's not painful. My question is, should I continue or should I never do it again?
Well, do you feel like it's coming more from your shoulder or your neck?
It is a shoulder.
Okay.
Forward, I don't have a problem. It is like doing this, and I heard too much.
Okay. So what you're doing is a range of motion exercise to maybe like increase blood flow and to kind of condition the muscles. When patients complain of either pain or they feel like it just pops too much, like they're going to injure themselves, I recommend isometric exercises. So isometric by the very definition means no movement, but you actually do resistant exercises versus a full range of motion. For instance, if you go to a physical therapist, there's physical therapists that'll teach you both, but there's most physical therapists, they'll try to kind of have you reach for a pulley or push a ball and do some light weights with high repetition. But if you have a pre-existing, let's say osteoarthritis or a torn shoulder, what you want to do is first condition the muscles that control that said joint. For the shoulders, those are the sits or the rotator cuff muscles. So you actually you use a wall and you actually put pressure on the wall. There's good websites that actually show you every range of motion But if you use a towel against the wall and you push up against the wall for external rotation, and then you rotate your body and you push up against the wall, internal rotation, adduction, abduction, you actually, if you hold it for about 2 minutes, you get pretty sore. And that's what the exercises they recommend for people who do range of motion. They feel like, I don't know if that's actually helping it or making it even worse, or people who already have a torn shoulder. So I heard there's really good physical therapy at Leisure World, so you can ask about isometric shoulder exercises. If you're looking for more information, you can actually go to a website called verywellhealth.com. And if you type in isometric shoulder exercises, it'll show you exactly what I'm talking about. I know I'm not a good explainer when it comes to that exercise. Verywellhealth.com. Verywellhealth.com. And I think it's one of those nonprofit, when COVID happened, a lot of these physical therapy groups were going online. So you could kind of look up the exercises and do them at your own house. So I think that's how that website started. So it shows a guy doing every range of motion isometrically. So it's not a video of him pulling on anything or lifting a weight. He just looks like he's standing there and he's putting some, there's 6 different positions for the shoulder, so you should try.
Thank you. What do you think about neurotransmitters, for example, lower back pain?
Neurotransmitters could be effective in certain kinds of back pain, especially with neuropathic back pain. So the difference is there's axial back pain and then there's radicular back pain. Axial back pain, just for the rest of you, is pain that stays or starts in your back and stays in your back, and radicular back pain is pain that starts in your back and, let's say, travels down the leg or elsewhere into the groin. The latter deals with a type of nerve pain that's more receptive to medications that have kind of a neuropeptide mechanism, such as gabapentin, Lyrica. Those are the main medications, and some people use Cymbalta, but usually the first line for radicular pain is a medication of that sort.
So these are the ones implanted?
Oh, no, those are medications. So by neurotransmitter, did you mean neurostimulatory?
No, things like Medtronic.
Okay, yes.
Transmitter and
Yeah,
implant.
so typically there is, especially for low back pain, there is a device that you could get implanted into your back that overrides a pain signal. Let's say if you're having a shooting pain down the leg, and that's a spinal cord stimulator. It's a battery-powered device. Yes, battery-powered device that you could get implanted that overrides a signal before the pain signal reaches your brain. Now, yes, there's a role for spinal cord stimulation, but it's typically implanted in patients who've tried medications, injections, and surgery. Most of my patients who have stimulators or get tested in the office actually have had at least 1 or 2 surgeries for their pain. But it's not only back pain, it could be peripheral neuropathy, it could be phantom limb pain, or just any kind of pain that could be overridden by this device. So if you haven't heard of this device, it's simply an electrode connected to a battery. The electrode goes upstream to an area of your mid-back typically, and it actually puts an electrical signal into a nerve. Now, all nerves are different, but there's certain nerves in the spinal cord, if you actually pass an electric current through them, they actually release a type of feeling often called a paresthesia. Paresthesia is sort of a tingling or a numbness sensation. Usually you could use this paresthesia to override a pain signal coming from another part of the body. Now, this is a type of last kind of line therapy in our clinic. We try a couple modalities, and then if the patients are still having pain, we do try that. Usually, typically patients with post-back syndrome or pain after surgery or pain refractory to surgery, but it's a battery-powered device that gets implanted. So you test it in the office, and if it helps you, you're typically referred to a surgeon who places this in under your skin, and the leads actually go into your spine. So, yeah. it's a little advanced, but it's something we do. It's less done for neck and arm pain because there's just a little less space for these electrodes to fit in the neck. And they do migrate once in a while. So the neck, because of the range of motion, that's a little bit more increased. I think the incidence of migration is higher, but for the back, there's less movement of the leads. So, good question.
By the way, keep an eye on the newspaper next Friday speakers.
What's your take on subluxation in chiropractic, on cell regeneration in lower spine, and acupuncture?
Okay, well, for the first part of the question, subluxation, well, I feel there's certain degrees of subluxation that we have naturally occurring in our spines, but sometimes this could be quite harmful, especially when you start to have subluxation, which is the movement typically of one bone against another bone. Because in our spine there's just so limited space, when you have a certain degree of subluxation, you start to create stenosis, and that stenosis could be problematic. Now, subluxation is sort of an active term. That means you kind of have to see it happening. So how do you really diagnose it? You could get an MRI and it could show that there's movement. If you look at two bones that are not completely lined up, and you could say they're subluxing. But typically surgeons and, your primary too could, they send you out for this flexion extension kind of x-ray to show dynamically if your bones are moving up against each other. If you're starting to have weakness, that's the biggest one. When you're starting to have issues with balance, starting to have some issues with weakness and falls, that's when it actually needs to be surgically corrected. In terms of chiropractic, well, I do send some patients to chiropractic doctors. I do feel there's a need for them. I do feel that there's therapeutic potential. As you know, there's a lot of political I guess not a war, but American Medical Society and the Chiropractic Society, if you look at the history, it's not a good one. So it's like a kind of, this society says this, and I think chiropractors are very helpful and they're vital for our community. Just keep in mind, if you have issues with bone health, if you're severely osteoporotic, you want to go to a chiropractor who's very case by case, and things like cervical traction and some adjustments have been found to be very helpful. And they're not the ones putting needles or anything anywhere, so they're very conservative, but they can be very helpful as well. Acupuncture, well, I don't really know exactly how it works, but I know it works for people. I have a partner in the office who does a lot of acupuncture, and it's a non-medication type of therapy, and it really helps for pain. The drawbacks of acupuncture is that you kind of have to commit to it, so it's multiple treatments, but it's helped a lot of patients in which our other conventional therapies haven't, so they're all.
Thank you. Can you stay and take a question if somebody wanted?
Yeah, sure.
The whole way?
We just have a booth here if you guys want some pens
And you guys come on in.
notepads.
He didn't know we're gonna have almost 70, so he didn't bring enough. Well, come on in.
Thank you, everybody.
Wait for Rod so after he left, I could still go for 5 minutes.
Michael, are you going to take a picture? Medium too? So I meant to ask you guys. Go ahead. Business card.